Welcome to Session 2. In this presentation, we will discuss steps to solving a medical coding exam case study. But first, I want to introduce you to the team. First up, Mr. Sandeep. Mr. Sandeep coming to you live from Abu Dhabi. He is an AMCI co-lead instructor. Next up, Miss Eva coming to you live from the state of Florida. She is also a co-lead instructor and the intern coordinator. And finally, myself, Mrs. J. I'm the curriculum director at AMCI. Now, let's meet the AMCI interns. We have Miss Anubama, followed by Miss Carla, Miss Courtney, Miss Dolly, Miss Vivian, and Miss Melissa. And the goals of the presentation are to review integumentary, musculoskeletal, and respiratory scenarios. Now let's talk about how to solve a multiple choice case study scenario the AMCI way for the board exam. This is how we do it. We teach you to highlight your key terms, and this key on the right tells you the colors that you should use and for what. A yellow highlighter should be used for diagnoses, all diagnoses, signs, and symptoms. The green will be for procedures. So if you have a green highlighter, the green will be used to highlight only procedures. And pink, these are inclusive or bundled items. All right? Once you've done your highlighting, you're going to have to document your inventory. That's your procedures, diagnoses, and select a primary code. Which diagnosis is primary, which procedure is primary. Then you're going to review all pertinent guidelines. And finally, the code that best matches your inventory list is often the correct code, or a code that is pertinent to a guideline. That will be your best code. All right. So here are some do nots. When you're highlighting, you can kind of get discombobulated. So we've compiled some things that you don't even have to highlight. Number 1, don't highlight things observed by the physician because you cannot code for them. Number 2, don't highlight closures. If a provider or surgeon is closing up a surgical site, there's no need to highlight it. However, if it involves a skin procedure or skin defect closure, you may definitely have to code that. So if it's closing a surgical site other than skin defects or wounds or lesions, you do not code it or highlight it. Also, you don't highlight bleed control, hemostasis, because that's pretty customary and it's bundled into the procedure code. You don't highlight drains, irrigation of the surgical site. Nope. And you don't highlight installation and removal of clamps and trocars because these are used to open up or maintain the surgical or operative site so the physician can view what they're doing, particularly if it's an open procedure. Also, you don't highlight dressings. And finally, you do not highlight surgical risks. Now that we've gotten that out of the way, I think you're ready to get started, and I'm going to hand it over to Mr. Sandeep. All right, Mr. Sandeep, take it away.
The respiratory system. I think we have got one more scenarios for the class today, coders. So are you ready for the final scenario, coders? Final scenario for the day, for the night. Sorry, it is day over here. It's like 5:10 here. That's why I'm getting confused. I know that it is night in your part. Okay, let's do it. And let me welcome Miss Vivian for the final scenario. Miss Vivian, you can take it.
Okay, coders. So the answers are A, 32601, modifier LT, 32666, modifier 51, S27.0XXA, V03.90XA, B, 32666, modifier LT, S27.0XXA, V03.90XA, or C, 32666, modifier LT, 31622, modifier 59, S27.0XXA, V03.90XA, or D, 32666, modifier LT, 31622, modifier 51, S27.0XXA, or and V03.90XA. Preoperative diagnosis, pedestrian in a MVA involving a car, left pneumothorax. Postoperative diagnosis, pedestrian in a MVA involving a car, left pneumothorax. Procedure, bronchoscopy, left vats, wedge resection. Procedure. Patient was brought into the operating room and placed in supine position. IV sedation and general anesthesia was administered per the anesthesia department. A single lumen endotracheal tube was placed for bronchoscopy per anesthesia. Due to the nature of the trauma, we were interested in ruling out a bronchial tear. The bronchoscope was introduced into the mouth and passed into the throat without difficulty. There was no evidence of sanguineous drainage or bronchial trauma noted to the left main stem. There were copious amounts of secretions noted and removed without difficulty. The right main stem was also cannulated and found to be free of unexpected trauma. The bronchoscopy was terminated at that time. A double lumen endotracheal tube was placed per anesthesia. The position was confirmed by bronchoscopy. The patient was placed in the decubitus position with the left side up. The chest was prepped in standard fashion with betadine, sterile towels, sheets, and drapes. A small incision is made along the upper border of the fourth rib just below the intercostal space, and a standard port placement was utilized to gain access to the thoracic cavity. An endoscope was inserted into the chest cavity. Initially, we had excellent exposure with good isolation of the lung. We identified a large bleb at the apex of the lower lobe of the left lung, which was likely to be the source of the chronic air leak. We removed the area of the large bleb at the apex with a wedge resection using thoracoscopic green load for therapeutic correction of the patient's pneumothorax. The wounds were closed in layers. Chest tubes replaced. The patient tolerated the procedure well and was taken to the recovery room. Okay, your time begins now.
Okay, that's more than 2.5 minutes. Thank you, Miss Vivian, for reading that final scenario for the day for us. And Curtis, I was just looking into the chats to some of the comments and the questions. Okay, I'm glad that most of them have got the modifier part here correct. Okay, let's do it, Curtis. This is a great scenario. So the correct answer to the question is option C. Yes, C is the correct answer. Okay, the first step, highlighting keywords, post-operative, pre-operative diagnosis are the same, and our diagnosis will be pedestrian in a MVA involving a car on the left pneumothorax. Let's see what's the procedure performed. It's a bronchoscopy and left VATS, wedge resection. The patient was placed in a supine position. General anesthesia was given. A bronchoscope was introduced through the mouth and passed into the throat. The secretions noted and removed. Bronchoscopy was terminated at that time, and then the patient was placed in a decubitus position. The chest was prepped. A small incision was made on the fourth rib just below the intercostal space. An endoscope was inserted into the chest cavity and identified a large bleb at the apex of the lower lobe of left lung, and removed the area of the large bleb at the apex with a wedge resection using a thoracoscopic load. So that's all happened in our scenario. And let's look into the procedure inventory. We are having two procedures performed here. One is a bronchoscopy and other one is a left VATS, which is a video assisted therapeutic surgery, and wedge resection was performed. In the diagnosis inventory, we are having a left pneumothorax and a pedestrian injury in a motor vehicle accident involving a car. Okay, now let me show you what a pneumothorax is all about. Actually, a pneumothorax is a collapsed lung, as you can see in the image shown on the left hand side. Pneumothorax occurs actually when air leaks into the spaces of between your lungs and the chest wall, and this air actually pushes on the outside of your lung that makes it to collapse. In our scenario, the patient was having a bleb. These are a small air blisters which can develop on the top of the lung, and these air blisters sometimes burst, which allows the air to leak into the spaces that surrounds the lungs. So we had a collapsed lung in our scenario. The patient was having collapsed lung, and the procedures performed. These are the two procedures performed. First, the physician performed a bronchoscopy, a diagnostic bronchoscopy, in order to check, due to the nature of the trauma, he was having a motor vehicle accident. So, in order seeing the nature of the trauma which he had, in order to check whether there is any internal damage or any other problems to the lungs, he performed a bronchoscopy, and later on he performed a VAT surgery, video assisted thoracoscopic surgery, and performed and saw like a bleb and performed a wedge resection of that bleb. This is how a video assisted thoracoscopic surgery looks like. There will be an incision made between the ribs, and the endoscope camera will be also placed in order to get a visual of what's happening inside, and the surgery will be performed, which might be a resection as well. So that's all about the procedure performed. And let's look into our mantra. Select the code that best matches your inventory. Code A, option A, 32601. And this is coding for a thoracoscopy diagnosis of lungs, pericardial sac, mediastinal or pleural space without biopsy. Now, 32601 is actually coding for a thoracoscopy diagnostic test. We had a bronchoscopy performed rather than a thoracoscopy in the first place. So there's a difference between a thoracoscopy and a bronchoscopy. That way, we can eliminate option A without looking into the second code. We'll come back to the second code in option B, 32666, which is coding for a thoracoscopy surgical with a therapeutic wedge resection initial unilateral. That's one of the procedures which we perform. As I said, it's a VATS with a wedge resection. Are you clear, coders, so far? Yes. Okay. But option B is also a wrong one. Why? Because this is only coding for a single procedure. We also had a bronchoscopy performed as well. That's why option B is a wrong one. This is a surgical thoracoscopy performed. We had a diagnostic bronchoscopy as well performed. And both are totally different procedures. Now let's look into option D, 3266, which is a correct one. As I said, video assisted therapeutic surgery or thoracoscopic surgery with a wedge resection. And let's look into the next one, 31622, which is bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, diagnostic with cell washing when performed. And only difference between option C and option D is a modifier. And why option C is a correct one? A quick reminder, coders, you can see the code 31622 is a separate procedure. Does anything comes to your mind when you see a separate procedure? Yes. Yes. That is a correct one. When you see a separate procedure, append 59 modifier, that is a general surgical guideline. A separate procedure, if not related to the primary procedure, use 59 modifier. So there was someone asking me why a diagnostic is not bundled to a surgical one. Well, the first procedure, the bronchoscopy, is not related to the second one. It's totally unrelated. As I said, bronchoscopy, in the first place, I said bronchoscopy was performed in order to see whether any internal damage is happened. And later on, a therapeutic wedge resection was performed, which was a surgical procedure. It was totally different procedure. It was performed in order to remove the blood which the patient was having. So both are not related. Is that? Yes, unrelated. It is an unrelated procedure performed, coders. So that is the reason why we selected option C as the correct one, following general coding, general surgical guidelines. Are you clear on this, coders? That was a little bit tricky. Yes, that was a little bit tricky, but a good scenario, a great scenario. So always remember when you see the separate procedure, when to use your 59 modifier and use of your surgical guideline. Yes. So
Thank you, Mr. Sandeep, for those AMCI amazing and awesome explanations. Miss Eva, for being the orchestrator and conductor of the best interns on the planet. Yes, I said it. Miss Melissa, Anubama, Courtney, Carla, let's get it, let's code, Dolly, and Miss Vivian. And let's not forget our interns in the chat, led by Miss Biji. And you, the students, you all are simply the best, and we appreciate you. And we will see you next time for more great scenarios. You don't want to miss it. And thank you for participating in the AMCI Medical Coding course. Until next time.